Welcome to the Health Informatics Seminar. I'm David Potenziani, faculty member here at UNC, and I will be hosting the seminar today. Please remember today's seminar is being recorded. Do mute your microphone if you're not the speaker while we're viewing the presentation. However, when we come to the Q&A segment, feel free to unmute yourself, pose your question, make your comment for the presenter to discuss. Alternatively, you may post in the chat where I'm happy to relay your question and comment, perhaps with a little bit of amplification. So let's begin. Professor Gurkan, please introduce our speaker.
Thank you very much. Good afternoon, everybody. I am Metin Gurkan. I am the Senior Associate Dean for Artificial Intelligence at Wake Forest University School of Medicine. And it's my pleasure to introduce our speaker today, Dr. Onur Koyun. He is an Associate Staff Scientist at Wake Forest University School of Medicine. Dr. Koyun earned his PhD in computer science from Istanbul Technical University in Turkey. His work focuses on artificial intelligence in healthcare, particularly computational pathology and deep learning for breast cancer research. Today's talk is titled Decoding Genomic Risk from Tumor Morphology. And this is really an exciting research that he's conducting here. And I think you will find it very interesting. In this presentation, Dr. Koyun will discuss how genomic assays such as Oncotype DX guide breast cancer treatment decisions, but remain costly and not universally accessible. He will then explore whether routinely acquired H&E whole slide images contain sufficient morphological information to serve as surrogate for genomic recurrence risk. And then he will present weakly supervised deep learning models trained on large multi-institutional data sets to predict recurrence risk directly from pathology slides. Importantly, he will also highlight a key challenge: prediction variability driven by intra-tumoral heterogeneity and slide selection. So these are incredibly exciting, cutting-edge, and important results that have big implications for many areas of healthcare, especially cancer and specifically breast cancer. So I'm delighted that he's going to give this talk. Please join me in welcoming Dr. Onur Koyun. Thank you.
Thank you, Dr. Gürkan. Good afternoon, everyone. And today I will present our work on decoding genomic risk directly from tumor morphology. Specifically, we ask whether routinely acquired H&E whole slide images can serve as a surrogate for genomic assays like Oncotype DX, enabling faster, more scalable, and potentially more equitable breast cancer risk assessment. So breast cancer is most common malignancy among women worldwide, but outcomes are highly heterogeneous. In early stage ER-positive, HER2-negative disease, one of the most critical decisions is whether to add chemotherapy to endocrine therapy. Traditional clinicopathologic models use like tumor size, grade, nodal status, and receptor status, but they lack sufficient predictive prediction for recurrence. Genomic assays like Oncotype DX significantly improved risk stratification, but they are costly, require centralized processing, and have long turnaround times. So the question becomes, can we extract similar prognostic information directly from morphology? Let's see how Oncotype DX works. First, the tissue is collected from tumor sample, and then RNA expression of 21 genes is quantified. These genes are grouped into biological pathways, and the final recurrence score, ranging from 0 to 100, guides treatment decisions. Patients with low scores may avoid chemotherapy, while high scores often justify it. It is powerful, but it requires molecular testing infrastructure. So our approach leverages something already available in every pathology lab, H&E images. By digitizing these slides and applying deep learning models, we can use this routine histology, perform rapid inference, reduce cost, and support personalized treatment decisions. These pipelines moves from resection to digitalization of slides to modeling entirely within the digital pathology ecosystem. So in internal testing, our model achieved an AUC of 0.89 on TCGA dataset with strong sensitivity and specificity, of course, and on an independent institutional cohort from Ohio State University, performance remained robust with an AUC of 0.86. This suggests that histomorphology contains reproducible signals aligned with genomic risk. Here is the technical overview. We begin with extracting tumor bulk from the whole site image and then extract patches from this tumor bulk, and a feature extractor generates patch level embeddings which represent the morphology of this patch, and these embeddings are aggregated and passed into a neural decoder. Importantly, we use a unified architecture that performs both continuous regression of the recurrence score and binary high risk versus low risk classification. This joint modeling improves predictive stability while preserving interpretability. Now, the key biological question is, how can an image predict a genomic test result? Oncotype measures expression of genes related to proliferation, estrogen signaling, invasion, and HER2 signaling. These are not abstract molecular events, they manifest biologically, and biological processes ultimately shape morphology. So, although Oncotype measure RNA, those pathways produce downstream phenotypes visible on H&E slides. For example, high proliferation genes correspond to increased mitosis, high nuclear grade, dense cellularity, and necrosis. Strong ER signaling correlates with well-differentiated architecture and lower pleomorphism. Invasion genes manifest as stromal reaction and desmoplasia. So morphology becomes a visible projection of underlying gene expression. Here are two examples. On the top, you can see what is called comedonecrosis, reflects highly proliferative and aggressive biology. And on the bottom, desmoplasia represents stromal remodeling linked to invasion-related genes. These are patterns pathologists already recognize, but our model quantifies them computationally. However, until now, we talked about predicting the Oncotype DX score from whole site images, but there is a critical challenge, the sampling bias. A tumor is heterogeneous. A single slide may or may not capture the most aggressive component, and AI models may analyze a non-representative slide, which creates a problem. So in this example, you can see the periapial region shows low pleomorphism and appears biologically favorable. The AI logic identifies ER signaling features and fails to detect proliferation genes. And then the predicted recurrence risk is low. but this is a false negative. The aggressive core is not represented in this slide. On the other hand, slide B reveals the true aggressiveness. We observe necrosis, mitosis, and desmoplasia on this slide. Now the AI identifies proliferation and invasion phenotypes. The predicted recurrence risk shifts to high. This illustrates that tumor heterogeneity directly impacts prediction. To address this problem, we aggregate multiple slides at the patient level. An attention mechanism allows the model to weight aggressive regions more heavily while downweighting benign areas. This multi-slide aggregation aligns computational inference with biological truth, capturing the most aggressive component of the tumor. So on external validation, patient-level aggregation consistently improves AUC compared to slide-level analysis. As you can see, different MIL architectures on slide level and patient level, there are a big difference on the AUC, and this confirms that heterogeneity-aware modeling improves predictive reliability. What's particularly interesting here is that when we compare the single slide attention maps with the multi-slide aggregation attention maps, they are nearly identical. In other words, the model does not fundamentally change how it weights patches within an individual slide. The spatial attention pattern inside each slide remains stable. What changes is not the aggregation logic, it is the available information. When we add an additional slide, the model simply receives new morphological evidence. And if that slides contain aggressive phenotypes, such as necrosis, high mitotic density, or stromal reaction, those regions receive high attention just as they would in isolation. The prediction shifts not because the model reinterprets the original slide differently, but because new high-risk evidence enters the decision space. This suggests two important things. First, the attention mechanism is stable and internally consistent, and the second, performance improvement arises from improved tumor sampling, not from altered weighting behavior. In essence, multi-slide aggregation improves prediction by increasing biological coverage, not by modifying the model's internal attention strategy. The model is behaving logically. It is simply seeing more of the tumor. So current Oncotype workflow requires centralized labs, long turnaround times, and high cost, limiting accessibility. A whole slide image-based surrogate model could provide rapid, cost-effective analysis directly from digital slides, and this may accelerate treatment decisions and improve equity in settings where molecular testing is not readily available. In summary, morphology encodes genomic risk signals. By leveraging deep learning and multi-slide aggregation, we can approximate genomic recurrence scores directly from routine histology. While the results are encouraging, there are important limitations. And first, this is a retrospective study. Prospective validation will be necessary before clinical deployment. And second, although we evaluated external data, broader multi-institutional validation is still required to fully assess generalizability. Third, we are predicting Oncotype DX, which itself is a surrogate biomarker, rather than directly modeling long-term recurrence or treatment benefit. And the fourth, as with all digital pathology models, scanner variability and staining differences may affect performance. And although aggregation helps to mitigate this, and finally, tumor heterogeneity remains a biological challenge. Even multi-slide sampling may not capture the entire tumor landscape. These limitations guide us to our next steps. So our next direction is moving beyond morphology alone. Tumor biology does not exist in isolation. We plan to integrate longitudinal mammography data, electronic health records, and digital pathology into a unified multimodal framework. And mammography provides temporal imaging signatures, and EHR captures comorbidities, treatment exposure, and clinical context, and pathology encodes microscopic tumor phenotype. By modeling this jointly and longitudinally, we aim not only to predict Oncotype DX more robustly, but ultimately to predict recurrence risk and treatment response directly. The long-term vision is a multimodal, temporally aware precision oncology system. It was the presentation of mine, and thank you. I would be happy to take questions.
So the first question is this process in place and being used at Wake Forest?
So we are planning to do a silent trial. So we integrate this model into our system, but not use to directly make a decision, but to evaluate if the model can mimic the actual Oncotype DX test and compare the results with the actual tests.
Do you plan, or how do you plan to use electronic health records in this approach?
Oh, so electronic health records that might or might not have different features from patient, like demographic features and age and other information. So we will integrate this information into our model. It's like, especially the age is very important for recurrence risk. Even with Oncotype DX model, selects different thresholds for different age groups. So basically,
okay. Is the Oncotype DX the current standard everywhere?
Yeah, as far as I know, for most of the breast cancer patients, if they are ER positive and HER2 negative, then this test is a necessity to decide if they need to get chemotherapy or not. So this is actually a subgroup of breast cancer, but I think biggest subgroup.
As a computer scientist, this is one person saying, have you worked with clinical experts, or did you learn the clinical aspects?
Sorry, I couldn't understand.
This is a question, I'm sorry, I misspoke it. As a computer scientist yourself, have you worked with clinical experts to understand their issues and then incorporate them into your approach? Or did you have to just learn the clinical aspects and inform your method of analysis?
I see. So we have pathologists and oncologists on our team, so they actually guide me to from my approach to the problem. So scientifically, like the approaches like AI and computer vision models, I pick the models and define the solution, but of course they guide me on the clinical side of this problem. So of course I'm not an expert on medical side, but I am trying to learn from them.
So how did you come to pick this particular problem?
Oh, I actually didn't pick the problem. It was a project of Dr. Gürkan, so I started working on that project. And
so, all right, so here's another question just came in. The heterogeneity you are picking up on, is it epithelial or stromal heterogeneity?
okay, so basically it's not just it's not just tumor heterogeneous, but it's also there are different aspects of it, like um, even when the staining is different, these AI models can make a wrong decision. So multiple slides just not only solves the heterogeneity on tumor, but it also solves other problems. So even with the same tumor, even for the same patient, if you get two different slides and apply staining, then these features of these different slides from same patients might differ because of the staining issues. So the goal is to solve this problem with more sample.
We have a question here in the room.
Yeah, I think that's kind of related to what you were talking about. I'm wondering if you have to deal with the presence of artifacts in the images of the slides, because I think it's a common problem. At least me, when I was a med student, it was
Yes.
really hard to identify what are real characteristic of the.
Yes. There are lots of artifacts, and we are applying some kind of we are applying some kind of regularization to our model to not to just learn these artifacts as like if there's artifact, it's high risk, and if there's no artifacts, then low risk. So this is kind of bias, and we put some guardrails on our models to not to learn this type of bias.
Do you plan to use this method to address other types of cancer?
So we are considering other type of cancer, but right now we are just working on breast cancer. Of course, this model is a general model and can predict any other biomarker on any other cancer, but right now we didn't try it.
Would this be applicable to diseases other than cancer?
Oh, like still looking at pathology, but not just looking for cancer, but other diseases?
Yes.
Yeah, of course. If you have enough data, we can model this problem with input and output relation. And still, of course, I didn't analyze it, but even for other type of diseases, this multi-slide approach might increase the performance.
So is the goal here to mimic the Oncotype DX process and determine if someone needs chemo, or could this be used to form the entire treatment plan, eventually type of surgery, radiation, medications, etc.?
Yes, of course, like this is our future plan actually, but we need a lot of data to because some patients get different surgery, some patients get chemo, and some patients does not get chemo, and there are lots of different variation of treatment plan, and some patients does not get like radiation therapy. So to model this kind of problem, we need lots of data, and in healthcare system, getting lots of data is very hard. So, and most of the time, the data we have, like they either get chemo or like most of the patients, it does not even have recurrence. So modeling it is really hard, and we need data with lots of recurrence, and it's like the distribution of the patients is not like that.
So would the inclusion of demographic data such as age lead to improved findings? Does your model have the flexibility to incorporate other kinds of factors?
I'm not quite sure I understand the question. So demographic data such as age improved finding? Is that the question?
Yeah, I think so. It's not my question. I'm trying to interpret it.
So we know from Oncotype DX, and there's a clinical trial called TAILOR-X. We know that for different age groups, Oncotype DX score works differently. For example, threshold for high risk patients is 25 in general, but if the age is bigger than 50, then this threshold lowers to 15. So they get more benefit from chemotherapy. So we know there's a clinical trial like that, and we know age is important. And the question is, other than age, is there any other information is important to decide if these patients needs to get chemotherapy or not? So the question we are asking with EHR data is this actually.
Would you used two different hospitals sets of data?
Yes.
In this sampling, or as you consider the future, would differences between hospitals in process, staining methods, scanners, workflows, cause the model to perform a little differently on different patients, or do you believe that those differences could be standardized in the model so that you would have the same level of confidence in the results from institution to institution?
Well, I actually believe we already minimized this problem because our feature extractor trained on approximately 300,000 of whole slide images. So it already learned all kind of different staining issues and different processes. And when you have this much of data, training data, the encoder, the neural encoder is the unbiased encoder. Yes.
Okay. Going back to your limitations slide, which of those factors do you think is most important to address next in the development of the tool?
Could you please repeat the question?
Going back to your limitations slide, you had several limitations of the research that you have, that you have noted. In looking at these, it looks like they could be addressed discreetly in future research. And if so, would you prioritize looking at each of these factors or try to address them all at once?
Oh, so we are, for most of the limitation, we have a plan, and we are trying to solve these limitations and work on them. Like for tumor heterogeneity, we will get more slides from each patient. And for sensitivity to staining, scanner, and institutional variation, there are some normalization methods that we are considering. And on the next project, we will directly predict recurrence instead of Oncotype DX. So one by one, we are working on them and trying to solve the issues.
So earlier in your talk, you mentioned the fact that this is faster and much less expensive than traditional methods.
Yes.
Do you see this as having a potential, assuming that you're able through your research to bring it forward to show that it is safe and effective? Would this be something that should be looked at by hospitals in low and middle income countries as well as those in the United States, Europe, Japan, et cetera?
I see. So basically, like what I think about this particular problem and modeling issue, that at first stage of this research, I think it should be used to like replacing Oncotype DX, but using this as a like if the model's confidence is very high to like patient is low risk, then maybe we can spare this patient from getting an Oncotype DX test. But if our model says like high risk or it's not that confident on the score, then we should do the Oncotype DX molecular test again. So it can be used as a first step solution, then the second step still the Oncotype DX test. Because if we only apply this model, and even though we have like high eosin performance and good calibration curves, we are not still sure that our model correctly defined the patient's outcome.
Granted, you're at sort of an earlier stage in the development of this approach.
Yes.
All right, last call for questions. There is one more in the chat. Has Metin taken you to his favorite Turkish restaurant in Chapel Hill?
No.
I have no idea which one that would be. Looking at my students here in the room, they have no idea. They don't go out to dinner.
We will not go without Ed. So if we go over there, Ed will already know the answer. We will never go to that restaurant without Ed.
Okay.
And this is being recorded, Ed. So
Yeah, Ed. So you've now been immortalized in your restaurant tastes.
So let us all know next week, Metin.
I think we need to close the restaurant. Yes, thank you.
All right, well, thank you. Oh, I'm sorry. One more question of some significance here. How did you strike an appropriate balance between large enough extracted features and processing times and processing requirements? How do you balance those?
I couldn't understand the question. Maybe.
Unfortunately, I'm not a pathologist or an oncologist. So
the question refers.
Go ahead.
The question refers to the size of the data that you're using for the extracted features, because sometimes I've heard that when that information size-wise gets too large, it becomes like a processing nightmare as far as when you're trying to use the algorithm.
Yeah, I see. So yes, it takes some time to process all these whole slide images because they are gigapixel images. We process it part by part and then feed it to our neural encoder and extract some features. It takes a lot of time, yes, but when you create your model and train it and finish it, the inference takes only 10 minutes for each whole slide image, maybe even lower than 10 minutes if the hardware is like, if you have a good hardware. So the training stage, yes, it takes a lot of time, but on inference stage, it's very fast and quick and cheap comparing to actual Oncotype DX test.
Thank you.
Thank you. And it sounds like every process in machine learning, it takes forever to set it up, to train your model, but once it's done, it's very fast and much more.
Yes. Yes, exactly.
Okay. Well, thank you very much. This has been a fascinating conversation, and we will see everyone next week when we are going to try out again our alternative format. We'll see you then.
Thank you.
Thank you very much.